Good evening. Welcome to Washtenaw Medical Beat. The topic for tonight is depression. To discuss the various aspects of this condition, I have invited two psychiatrists from Washtenaw County. Let me introduce Dr. Thomas Siegel, a psychiatrist in private practice in Ann Arbor, also an adjunct faculty member, University of Michigan Department of Psychiatry. And Dr. Michelle Reba, Professor and Associate Chair for Integrative Medical and Psychiatric Services, Director of the Psych-Oncology Program at the University of Michigan, and also Associate Director, University of Michigan Comprehensive Depression Center. As an aside, she is also a past president of the American Psychiatric Association. Welcome to you both.
Thank you
so much.
Now, Dr. Reba, if I may start with you, what is depression?
All of us from time to time get sad or get irritable, have a hard day. But what we're talking about today is major depression or clinical depression, which is a medical condition. This condition can occur throughout the lifespan, from young to old. And in major depression or clinical depression, one has a change in mood, behavior, thoughts, or feelings that lasts for at least 2 weeks. Every day somebody has a change in mood or their feelings, and also affects functionality, either at work, at home, their relationships. There has to be a change where somebody feels something different has occurred and where they don't feel well. And that's sometimes very difficult to parse out for some and needs medical attention. There are associated symptoms that go along with major depression, and they can occur in sleep or appetite, concentration, energy, hopelessness, helplessness, and sometimes suicidal feelings.
And you say this can occur at any age. Dr. Siegel, in your practice, what age groups do you see most commonly?
In my practice, I don't see children or adolescents, so I see patients from 18 years old on up to senior citizens, and depression can occur at any stage in life. There are difficult transitions all through life, and people can get depressed in any of them. The major depression that Dr. Reba is describing is an abnormal mood state that develops. It's a progressive problem. It's persistent, meaning that when people fall into a state of depression, they don't have good days interspersed. Every day is painful for them.
And why is depression a problem? I mean, everybody can feel down or blue. What changes unhappiness into depression that requires your attention?
We don't actually know for any individual person what may trigger this. We know that there are some associated risk factors, such as alcoholism, major medical conditions, a past history of depression in either a person or their family. And so there are risk factors, but the reason why this is so critical to evaluate and then treat is that if it doesn't get treated or evaluated properly, people can not be able to function or be happy or do well in life. They may have to become disabled from work or drop out of school or have difficulties in their home lives with their loved ones and friends. So the good news, it's very treatable in most cases if it's recognized and evaluated, diagnosed, and treated properly.
There are some people for whom their depressions get triggered by certain life events, major losses, setbacks. That doesn't necessarily predict who will become depressed and who won't. I think the risks are in a number of different categories, certainly in terms of genetic predisposition for some. Those who have significant and serious losses. And it also depends on the coping style and coping mechanisms that they have at their disposal to deal with the stresses. But often you'll see some precipitating event.
But you said earlier that suicide is sometimes goes along with depression. So does this mean it is commonly or consistently a fatal condition?
Not consistently, but it's not uncommon for people who are depressed to think about suicide. And part of the job of the psychiatrist in evaluating that is to flesh out the details, to find out who is thinking about suicide just as a measure of their pain and suffering, and who is at risk to act on thoughts or impulses.
And what is the incidence of problems globally from depression?
Well, it varies depending on, the specific population you're looking at, but it usually occurs in women compared to men, and about 115 million people probably globally have depression at the current time, or suffering with depression. And one of the problems is that people may have depression and then not get diagnosed or treated properly. So that's a major issue for the world.
So what is the treatment for depression?
There are many treatments for depression, various forms of psychotherapy, in addition to pharmacotherapy medications, are probably the most efficacious. And then there are other treatments, such as electroconvulsive therapy as well, peer-to-peer counseling, and group therapy, as well as individual and family therapy.
Now you say electroconvulsive therapy. Do we still convulse patients?
Electroconvulsive therapy is a very safe and important therapy for certain types of patients with certain kinds of depressions.
But the convulsions, I hope, have gone since anesthesia.
That's correct. That's correct. It used to be that the electrical shock was administered and the patient actually had a physical convulsion.
Is that how it got its name?
Yeah.
Yes.
Yeah. And under current conditions, it's much safer. There's an anesthesiologist in attendance. The patient's musculature is temporarily paralyzed, so there aren't any convulsive movements which could injure the patient. And the voltage on the electricity is much less than what it once was. And there are certain forms of very deep and serious depression where medication, you don't have the time to administer medications and wait to see when they might start to work. For instance, people who are virtually catatonic and not eating.
Oh, what does catatonic mean?
Basically motionless.
But you know as an anesthesiologist that it's a very safe type of treatment. It's a very controlled and and done in a hospital setting usually. And we even do outpatient electroconvulsive therapy for some people who need it on an ongoing basis. So,
sometimes it's the only treatment that's effective for
Yeah.
patients,
Yeah.
and when needed, it can be life-saving.
How do you define effective treatment in depression?
well, that's a very good question. There are a number of ways to think about this. There are scales that are used now, measurements that can be done by patients themselves or can be done in conjunction with their providers, looking for the various symptoms of depression and then trying to determine how severe those symptoms are. So the PHQ-9, the Patient Health Questionnaire 9, or the Beck Inventory, or the Hamilton Depression Scale, or some scales. There are scales for the elderly, there are scales in children and adolescents and for middle-aged people. So they've been correlated and validated and are quite reliable. So there are those scales. In addition, the patients themselves, in working with their clinician, can talk about how their functionality, how they're doing, how they're concentrating, how they're sleeping or their interests and activities. And then family members are very, very important, getting their input into how their loved ones are doing.
Do you have to advise families of patients? I mean, it must be a very difficult problem for most families to live with.
Well, you know, this is a conversation and a joint partnership between the clinician, the patient, and the family regarding how one's doing and what the goals are, and getting information and collateral information to try to put together an understanding of where the person is now, where they were, and what the goals are for care.
Do you find in your practice patients and their families are cooperative with one another?
Sometimes yes, and sometimes no, and that's part of the problem. Yeah, there are times when it's very helpful to consult with the family. Certainly, in my experience with elderly people, it's extremely helpful to see them together, see the spouse with the patient, because there's so much concern in later years about failings when people start to fail and get infirm, and they get frightened. And they get frightened when there's something wrong with their partner, because I think as we get older, we tend to rely more on our partner. And sometimes it can be very helpful to a spouse or even to adult children. It can be very helpful to them to help distinguish what they need to worry about with regard to the depressed family member and what they don't need to worry about. Whether that relates to changes in mood, mood and behavior, medication side effects, or whatever.
So if you have a family member or a friend who you think is being affected by depression, who do you go to see?
Well, I think that it's very important to see a psychiatrist.
But is that the first stop?
Well, I think we would probably agree that one of the first stops might be going to see a primary care physician. Often people have a long-standing relationship with their family doctor. And it could be that there are some medical conditions that may look like depression but need to be screened out, such as, for example, hypothyroidism or anemia or hypertension, heart disease. maybe conditions or the medications that people are on for these conditions may be risk factors for depression. So, you know, going to see a primary care doctor and then perhaps a referral from the primary care doctor to a mental health clinician, either a psychiatrist or other mental health professional.
Because I think probably one of the most distressing conditions is postpartum depression. Not only affects the immediate family, but two sets of grandparents as well. Is there any special way of dealing with that?
That's a very, very important area, and I'm glad you brought it up because, you know, many women have the blues or have some lowered mood after giving birth. It may be due to hormones or changes in sleep or the additional burdens that one has with that. But, and nowadays more and more women are not going back, don't have very many follow-up visits to their OBGYNs where that could be screened. But we understand that this is an incredibly important time in a woman's life and in a family's life where there may be changes that are going on in the family and are difficult, and mood problems are one of them. So it's very important for pediatricians, family members, and the woman herself to really think about this. If there are some changes in mood, appetite, already sleep problems with a newborn, irritability, energy, concentration, and to seek professional help, hopefully with a psychiatrist or other physician.
So, on the basis of these comments, in your practice, what do the most frequent source of your patients? Is it self-referral, family bringing somebody in because they're worried, or is it referral from a third party?
I think mainly self-referral. I do get some referrals from the medical community as well. But I think a lot of people are quite motivated, even though they may be apprehensive about coming, quite motivated to do something to help them when they're feeling bad.
Well, of course, one of the other problems that we hopefully have cured is the lousy coverage that insurance companies give to mental illness. And I can't help feeling sorry for the young parents who can hardly afford a child, let alone any treatment for postpartum depression. Do you feel that the ACA is going to make a difference?
Well, we certainly hope so, but anybody who is depressed, and especially in the postpartum arena, should not worry about depression and seek medical attention. Come to the emergency room, see their family doctor, OBGYN, and hopefully nobody should go unattended to if they have depression.
Can you tell us a little bit more about the medications you may use to treat depression?
Well, there are a range of medications. There are the older medications that sometimes we still use, the tricyclic antidepressants, but nowadays we have what we call selective serotonin reuptake inhibitors. And the first one was really Prozac or fluoxetine. And then there have been others that really, in general, have a very safe and effective side effect profile. They're usually very well tolerated, and what we try to do is look at the side effects and look at the patient's needs and try to mesh them. So, for example, some of these agents, for example, some of them may keep people up and activate them, and some of them may help with sleep if you're not sleeping well at night. And so we try to talk with our patients and try to understand the symptoms of depression and the side effects, and then use the right medications. There are also medications that help stabilize mood, such as lithium and Depakote and Tegretol are some of those. And then there are anxiolytics, because often anxiety travels with depression, so sometimes we have to use another medication to help with the anxiety if the antidepressant itself doesn't help.
It's not always easy to tell which is the primary problem.
Yes.
It takes some careful attention to it, because there are many people who come in and complain of depression initially, and when you really start to hear the details of it, it's clear that the biggest interference in their life and what causes the most distress is anxiety, and that the depression is secondary to that. In other words, more like discouragement at having to live with their anxiety problems and the interferences.
What do you find is the commonest risk or side effect that your patients subject to with commonly used antidepressants?
Well, the most common antidepressants are the newer group of antidepressants. As Dr. Reba said, Prozac was the prototype drug. There are others a handful of others in that group: Zoloft, Paxil, Celexa, Lexapro, and those are the most commonly used for depression and for anxiety, because they're very useful in treating anxiety, even in people who don't have any depression. And the commonest potential side effects, and I want to underline potential, because the majority of people can take these medications at therapeutic dosages without any side effects at all. But the most common ones for that newer group, so-called SSRIs, weight gain and sexual function. And if you think about sexual function in three ways, at least I do: the ability to be interested in sex, the ability to get aroused, and the ability to have an orgasm. These antidepressants mainly interfere with the third function, so that they make it a little more difficult to achieve orgasm.
Mm. And how do you find patient compliance with prescriptions?
Well, I think that depends in large part on patient education and defining the venture as a cooperative one, so that if the doctor adopts the attitude with the patient: look, this is something we're going to try together, we have to work together, here's what you need to know. If there's any question or problem, you can call me and we'll deal with it at the time. So I think that just doing something simple like that increases the chances of a cooperative patient.
Many times patients don't even fill their prescriptions or don't take it in the way that they should, or don't understand the instructions. So as Dr. Sagal was saying, this patient education is very important, allowing the patients, asking patients to call, if there are any problems, in seeing the patients very soon after a medication's prescribed, often starting low and going slow for the elderly patient to try to ward off unnecessary side effects. And also talking about how much medications are going to cost, because sometimes people are ashamed or embarrassed to talk about the co-pays that are necessary, or not wanting to have the most expensive medications and to start with a more generic kind of medication. So these are important conversations to have. And what we've also found is that it's not just the medication, but the psychotherapy that goes along with the medication really is the most efficacious.
So really it's a joint effort between the psychiatrist and the psychotherapist? Or
yes.
are you doubling up?
Well, That depends. I think there are many psychiatrists, especially in this town,
Yes.
who do a lot of psychotherapy and are quite well trained in doing that. Whether the psychiatrist who's prescribing medications chooses to be the psychotherapist as well, that may vary from case to case. But yeah, I agree with Dr. Reba. The therapy is very important because the depression is a symptomatic reaction to stresses in a person's life. Even for those who have a very large genetic loading, creating a situation that's similar to somebody with diabetes that's hard to control. Small stresses may influence the level of their symptomatology. But I have always felt that there's no medication that's going to help you work out your problems in life.
Yeah.
But there are a lot of medications that can make people feel better and make it easier to work on those problems. So that combined treatment is probably the most effective of all.
Do these remarks apply equally to bipolar disease and seasonal affective disorder? Is it the same sort of problem, or to a lesser degree?
Well, it's interesting that you asked that. In the latest Diagnostic and Statistical Manual that just came out in May of 2013, the American Psychiatric Association nomenclature, actually bipolar disorder used to be part of the depression grouping, and now it has its own category. So it used to be felt that this was a continuum and that depression and bipolar were in the same category, and we're learning more and more that it's its own distinct disorder. But in bipolar disorder, people do have episodes of major depression, but also have the opposite of major depression, low mood, which is a high. They feel meanier, or they have excess energy. They can be very irritable, hypersexual, grandiose. And so it's sort of this bipolarity of mood.
Let me just cut you short on that one, because there's one question I'd like you to answer. We're running out of time. What is the Depression Center at the University of Michigan? What's it for?
The University of Michigan Comprehensive Depression Center is the first depression center in the United States, so we're very proud of that. It was started in 2001, and it's a unique opportunity for us to provide the best care, cutting-edge research, train the next generation of mental health clinicians, and work in partnership with our colleagues throughout the medical center, with the community, with volunteers, with patients and families, on trying to better understand depression and bipolar disorders.
So it's primarily a team effort.
It's a team effort.
In the hope
Yes.
of acquiring more knowledge.
Right, and now we have, I guess we have depression centers throughout the United States now. In linkage, we're called the National Network of Depression Centers.
Sincerest form of flattery, isn't it? Well, I'm afraid we're running out of time. So allow me to thank you for coming here this evening and answering the questions. And I hope it's been helpful to our audience. Thank you very much.
Thank you.
You're welcome.